And Dr. Pintar was a private pediatric practitioner for over 25 years, mainly here in Carson City. She emphasized special needs children, and she was very close to her heart. She became the health officer for Carson City in 2009, and she serves as chair of the Board of Health. Dr. Pintar serves as chair of staff for the Carson Tahoe Hospital, and she's president of the Carson Douglas Medical Society and CME chair for the Nevada State Medical Association. And along with her, keeping with her passion, she is also presently the medical director for the Eagle Valley Children's Home, and she consults for Nevada Medicaid. So without further ado, let's open up our program with a round of applause for our moderators, Dr. Pintar.
This will be the fun part for me, because I don't have to worry about speaking for 20 minutes. The forum will be held in much the same way that we did last time, which was that we will have our three speakers. They will each be speaking for 15 to 20 minutes. What we would like you to do as the audience is to record any questions or things that you would like commented upon on the white cards that are handed out to you. And if you would pass those to, I'm wondering if the middle or the ends. Probably the ends would be better. And Kathy or Judy or one of the staff will pick those up, and they'll be collated. Are they not there? No. White cards?
No. They were at the front desk.
They're at the front desk. Some people pick them up. We'll bring some around. We'll pass them in. And then those cards will be compiled into like questions, so to speak, and at the end of the presentations, we will have an open question and answer session based on those cards. Our first forum addressed the general outline of the Affordable Care Act and the impact of that this legislation will have. We included some overview presentations, as you may remember. One was from the now director of the Silver State Health Exchange. We also had representative of the federal government, and as well as my talk about how the Affordable Care Act might affect us in a general way from a public health perspective. Tonight's forum is looking more at the nuts and bolts of the Affordable Care Act. We and the Sierra Nevada Forum got quite a bit of feedback about how am I going to be affected? What effect will this have on my healthcare personally? How will this affect healthcare in Nevada? And so we have a panel of very good speakers to talk to those issues tonight. I will do a little brief introduction of all of our speakers right now, and then introduce each one as they come up. Our last speaker will be one of my good friends, Dr. Sandra Koch. Many of you have known Sandy. Sandy graduated from Tufts University School of Medicine, New England School of Medicine, only a couple of years ago. She completed her OBGYN residency in Colorado, and she and her husband moved to Carson City in the early 90s, where she's practiced primary care OBGYN since then. She's on active staff at Carson Tahoe Medical Center, has served on numerous committees, and is a member of the Carson Douglas Medical Society. Sandy and I have been soccer moms together and hockey moms together. One of our proudest moments is that our sons have all their natural teeth. It would be difficult for us to find a more caring and compassionate physician in our community, and I'm very pleased to have Sandy come speak with us tonight. Deborah Scott is also here with us. Deborah is currently the Executive Director of the Nevada State Board of Nursing. She has a long and varied career in nursing, having served as staff nurse, clinical coordinator at a number of hospitals, and is also received her master's degree and has worked as a nurse psychotherapist at mental health facilities. She joined the State Board of Nursing back in early 2000s and has served as its executive director since 2002. And last but not least is our first speaker tonight, Larry and I also go back only a couple of years, or 25, one or the other. Larry is currently the Executive Director of the Nevada State Medical Association, a position he has held since 1988. He has a wonderful background in healthcare and healthcare administration. He was the former administrator of the Nevada State Health Division, as well as the Executive Director of the Clark County Coalition of Health Systems Agency. Larry is often asked to speak and on television and radio for his perspective as the Executive Director of the Medical Association, and probably has one of the most difficult jobs in Nevada. Herding doctors is much like herding cats, and Larry has done a superb job of that for the last 25 years. So I would like to now introduce Mr. Larry Mathias, who will begin our forum.
Yeah, there we go. Okay. Well, thanks for coming out on a blustery night. The Affordable Care Act is one piece of the federal health care reform initiative. And it's put together a lot of different things that don't necessarily make sense together, but that's the price of 60 votes in the U.S. Senate. And out of it, a lot of people are now trying to actually find a way to implement what the intention is of the High-Tech Act, which creates the pathway to having electronic health records, and the various workforce initiatives to train more people to be able to work in things. But the Affordable Care Act is the key piece because it tried to address coverage issues. How many of you are covered by Medicare today? Let me tell you what's going to change for you. Nothing. However, 2 years from now, nobody can say today that Medicare won't be substantially changed. That was one of the reasons for the Affordable Care Act. Both parties agreed that sustaining Medicare is not possible given the realities today. The Medicare program is going to increase by over 40% in the next 3 years. In Nevada, we will have about 700,000 Nevadans on Medicare within the next 2 years. The baby boom is moving into Medicare. And I guess now we're the aging boom or whatever, but the senior boom perhaps. But it is a frightening thing for a program that stopped totally paying for itself about a decade ago. When Medicare was created, it was fairly easily and fully funded jointly by your employer and you as an employee. And it went into a trust fund. And there really was one. But that stopped when the ratio of those on Medicare and those contributing to Medicare became closer and closer together, because the cost of treating in Medicare has to be the highest because of any coverage program, simply because of the likelihood that we're going to use services. Another couple of months I go on it too. I'm part of the problem. I'm part of that senior boom that's happening. And it's a boom that will collapse that program if there aren't some fundamental changes made in the overall healthcare system that feeds into it. That was the logic that both parties had, that both sides had talked about for a generation, and only now begin to sense that the immediacy of having to do something. Restructure how services are delivered. Restructure what services will be delivered. But anyone who says they know how this is going to turn out is simply not being honest with you. They're pushing some idea, they're pushing what they hope, perhaps. The Medicare program, making it sustainable, was a cornerstone of why Congress felt the need to act. How many here are actually on Medicaid or have a family member who's on Medicaid, maybe in a nursing home or something? Nobody? Well, that group, I can say that within the next year, will see huge changes. For the Medicare population, you age into that coverage. For the Medicaid population, traditionally, in Nevada, since we're 51st in eligibility, you had to really be in trouble to get into Medicaid. But the Affordable Care Act, there's been a lot of talk about the Medicaid expansion. The Medicaid expansion is not all that important or all that relevant over the next couple of years. It's interesting. What it's done is gone back to the original ideas behind Medicaid back in the 60s. Medicaid and Medicare passed about the same time. And the issue with Medicaid was we had a fairly robust welfare system. And if you were in any way qualified for welfare, you were qualified for Medicaid, indigent medical care. That tie was broken during the Clinton administration when they eliminated the federal welfare program, and that meant that they severed the relationship between income levels and being on Medicaid. And so it more for people with significant problems, medically needy, and some who are in the what replaced welfare was a temporary program, a temporary relief program, and many of the people who went on it when it became temporary are still on it. So I don't know how long temporary is, but that seems to be. But the TANF population. But again, Nevada is at the bottom of the heap in terms of qualifying for Medicaid. That radically changes with the Health Care Act. For one thing, it changed the rules of who can qualify for regular Medicaid. When a pregnant woman who's uninsured presents at the emergency department for delivery, right now there's no guarantee that there's coverage for whatever it costs for the delivery of that baby. The law changed with the Affordable Care Act. All states have to presume eligibility when someone who is uninsured comes into the emergency department and for those services. That's going to be a big hit in Nevada because we've used the lack of presumptive eligibility as a way of keeping the number who are in that program down. The assets test is used in Nevada as a way of making sure that people who have any ability to pay won't get on Medicaid. But that's why we're 51st in the country. That rule goes away, and states like Nevada will have to have those people in the Medicaid program. In the budget wars that are going on over the legislature, that and not Medicaid expansion is going to be the cost in the budget, because there's going to be a huge bump of people who are currently uninsured, floating out there, who will now be qualified for the Medicaid program. The Medicaid expansion goes back to the welfare days. The qualification there is for adults and for adults who have a low income below 138% of poverty level. And that's going to be a significant program. These are folks, again, mostly working uninsured, mostly young adults, and presumably they're not going to be using a lot of medical services. But that's a new program, a new facet of Medicaid that over the next coming years is certainly going to grow, unless the next part of the reforms happen. How many of you are insured either through your employer or a union or have your own personal insurance? How many of you know if your plan has been grandfathered? 80% of Nevadans who have insurance today will have exactly the same insurance next January. Because almost all coverage, either from self-funded plans or from labor plans or from group plans for employers, have been exempted from this first round changes in their rules. And what you have is an awful lot of these. The employers or the plan administrators are waiting to see what happens with commercial insurance. And so I think for everybody on Medicare, no changes in the next few months, in the next year. For those who have insurance today, if you're in a grandfather plan, and you probably are, you're not going to see any changes. So where are the changes? And the changes are that new commercial insurance products are going to be regulated either by federal regulations that have been developed, in or out of the exchange, or by qualifying and being available to everybody on the exchange. And the Silver State Health Insurance Exchange is busily trying to construct the program. A problem: the federal government didn't start writing the regulations until after the elections. So they're coming out slowly. But you can't go that slowly because the plans are supposed to be available for people to shop starting in October. So dealing with the federal government is certainly always interesting, if not inspiring. And I think that's what we're going to be facing. What is this exchange? And who's going to be on it? My prediction is that very few are going to be on it at first. That it starts in January of next year, and there will be a portal that's cost several $1 billion. And I think ours is going to be run by Xerox. But it'll be for anybody on Medicare. If you've done Part D, if you go on the computer system and you've got this one that provides this one that provides that, and they're going to be but the difference is this could be full insurance, and there'll be different levels, and each level will have a minimum set of requirements, and then the plans can go over those. So there's going to be navigators and brokers and all kinds of assisters there to help everybody try to sort through this. But it's for obviously those who are uninsured, mostly working. They're above that 138% of the federal poverty level, and then up to wherever they want to buy. Everybody can buy on it. There'll be individual plans, and there'll be plans for small groups, which have been probably the hardest to cover. But who is in that group that's going to actually go on that? We don't know. 40,000 maybe altogether for a while. But those of you who are on commercial plans that have been grandfathered to current policy, when policy changes, then it has to either meet the federal rules, new federal rules for insurance, or it has to be on the exchange. And those decisions are going to be made, I don't think this fall, I don't think next winter. I think it's going to be 2 years, 3 years, 4 years down the road as we see the system breaking through. In the meantime, all of this coverage, which will presumably mean that people who were going uninsured, having to pay cash, having to use emergency departments, whatever, most will be covered. But again, it's likely that 10 or 12% of the veterans will still be out there without insurance. So what will happen this year? A lot of things are going to begin to be offered. Next year, people will be testing the new Medicaid eligibility, testing the new exchange. They'll be waiting to see what works and what doesn't work, what's better than they've got. And we'll still have a large chunk of Nevadans who will be uninsured. And we'll still have to be making arrangements for them to be covered. In the meantime, and throughout all of these experiments, which is what they are, there's going to be other things going on to change the system in which these services are delivered. And these experiments, again, are just that. So you'll hear a lot about accountable care organizations, which is a new form of managed care, which are trying to put physicians, hospitals and insurers together in a new formulation of integrated service delivery aimed at payment that will come for outcomes or for packages of services. Will it work? Maybe. Will it work for everybody? Probably not. Will it work in every community? Probably not. But it's a theory that's going to be tested primarily with the Medicare population. Same thing with medical homes. An idea of having an integrated group under a physician that provides a range of services, preferably to try to keep people from needing many chronic disease services by early intervention, by managing the practices. The assumption is that those things will take the pressure off Medicare, take the pressure off the system that's going through so many changes. And we'll see if it does. Payment reforms are going to be tested. But we have a workforce that's barely able to deliver what's needed today, and they're going to be challenged to be delivering more to more people in a very short period of time. And that's certainly going to be part of everybody's experience. If we have electronic health records up and usable, that should make the system more efficient. There's no reason to think it'll make it cheaper. And there's no reason to think that it's actually going to work as intended. Because my experience in the healthcare system is nothing works as intended. And everything has to be worked through with real people trying to do the best they can at either end, either as a patient or as a family member of a patient, a doctor, a nurse, that we're going to be testing new systems at the same time that all of these other changes are going on. And we have to make it work. That the individual patient is going to have exactly the same needs this fall, next year, 2 years from now, 3 years from now. Those needs aren't going to change just because we change the system. But making, especially for intergenerational changes, for young people today to expect a primary care system much more than a specialty care system, to expect to not to have, perhaps, treatment for every problem that they have. To change the culture of our country over time, partially by what we will pay for, partially by what we won't pay for, partially by these attempts, some of which are going to fail, and some of which are going to succeed, and pasting together a new healthcare system. The Social Security Act in 1934 didn't deliver anything until the mid-50s. The system had to be totally reworked several times to actually do what it was intended to do. Medicare, passed in the mid-60s, was a failed program until the mid-70s, when major reforms of it were adopted. It takes a while to know, even if you're going to go a particular direction, it takes a while to know what doesn't work. It has to be fixed. And I'm letting you know a big secret. Congress has trouble doing things. And the unfortunate thing about passing these things as federal statutes is that they can't be regulated away if there are basic problems. At some point, Congress has to get back into the game and has to find a way to make it work. In the lead up to health reform in those 2 years that we were debating it so pressed, I used to quote from Otto von Bismarck for a couple of good reasons. He developed the medical care coverage system in Prussia. And he set the age for qualification at 65. And the major reason for that was the average age was 59. When we did it in the 1930s or in the 1960s, we set it at 65 because the average age was 62. So sometimes those things get a little bit away. But mostly for Bismarck's remarks, we all know about his thing about don't let the sausage or laws being made. And that certainly is true if you watch C-SPAN. But a more important one is that politics is the art of the possible. And what these laws that are our healthcare reform initiatives were what it took to, in the world of the possible, to actually pass. They're making major changes. And we all have to live with them and make sure that we blow the whistle when a reform isn't working. And that we deal with our congressional delegation, deal with your healthcare giver, to make sure that you're on the same wavelength about what's working, what's not working, what your expectations are, when they're not met. Those things are going to be very important. Even if the basic system doesn't change immediately, the changes are going into effect. And you need to be as much a participant in guiding those changes as those at the top, or as the doctors and as the politicians. That's a new role for us as individuals. And it's one that the healthcare system has rarely consulted with patients and patients' families to really make fundamental reforms. I think in this process, it's the only way we're going to make the reforms work at the end. So thank you very much, and I look forward to questions.
Thank you, Larry. That was great. And I'm going to build on some of what Larry started to say at the end. And that's about how important each of you are as consumers of healthcare. Now, I have to look this way. Consumers of healthcare, because you're the ones who have to take responsibility for being healthy. I'm going to talk a little bit about nurses. Did you know that nurses have been planning for 10 years for what's coming now, coming to fruition now? How many of you have seen those commercials by Johnson & Johnson where people say, I'm a nurse? Yeah. And the next person says, I'm a nurse. And it's minorities, and it's men, and it's young people, and it's older people. Nurses, in fact, we have about 4 million nurses in the United States. We have close to 40,000 individuals, CNA nurses, RNs, LPNs, and advanced practice nurses in Nevada that are going to be an integral part of what happens with the ACA. And I want to just give you some information tonight about what that might look like and how you can be part of that. In 2010, the IOM came out with a report called The Future of Nursing, Leading Change, Advancing Health. And that report says that nurses need to be a big part, need to be an integral part, need to be at the front of what's happening with healthcare. And nurses want to do that. And we have enough of us so that we can be very much involved in that. And so let me tell you how Nevada has ramped up to provide the nurses to be able to be involved in the care that is going to be given and that is already being given. About 6 years ago, in Nevada, we doubled the enrollment in nursing schools. Not only did we double it, but the legislature didn't give anybody any money to do it. But we did it. And then it was funded. So it's like build it and they will come, and that's what happened. In addition, from the IOM report, it says that nurses need to be involved in lifelong learning, in that you go into nursing, maybe you start out as a CNA, and then you be an LPN, and then you're an RN, then you get your bachelor's, and then you get your master's, and a lot of nurses now have doctorates. About 1% of nurses have doctorates now. And I started out as a CNA, got knocked in the jaw when I worked nights at a long-term care facility. I was one of those nursing students who was old when I started. I had 2 kids at home. I worked really hard, got my bachelor's in nursing, and then went back and got my master's within 5 years. And I have an advanced practice nursing certificate that is on inactive because this job doesn't let me do that fun stuff. You just get to do regulation. So we actually doubled the enrollment, we're now looking at nurses who have an ADN, because you know there are RNs who have ADNs, associate degrees, and then also have a bachelor's degree. And so the programs that educate those nurses to become bachelors of nursing rather than ADNs, those programs are adding slots by 30, 40, 50 here in the state of Nevada. And so we're educating those. And in fact, we have just recently increased the number of nurses who can be nurse practitioners, and also have a new program called a Doctorate of Nursing Practice, which is a program that is shared by UNLV and UNR. So a lot of things nurses are doing to be able to have the information and know how to be part of this delivery of care that is going to be changing in how we do that. The number one thing is what? Safety. Right? We have to be safe, we have to have quality care, and we have to be efficient. And so some of what you see in the ACA is looking at electronic medical records. It also is looking at new ways of delivering care. So you've heard of the medical home that Larry talked about. There is about 200, let me get the exact number. I think it's about $20 million that is specific to help nurses create clinics that are nurse-run by advanced practice nurses. How many of you have ever been treated by a nurse practitioner? Okay. So you know what nurse practitioners do. Nurse practitioners are nurses, RNs, who have an advanced degree, either a master's or a doctorate, and they also have national certification in their specialty. So nurse practitioners are ready and able to really help with those primary care needs. We're going to have an extra 280,000 people just in Nevada that are going to need primary care in the very near future.
Excuse me, could you tell us what IOM means?
Yes, that's the Institute of Medicine.
Thank you.
Yes, I'm sorry. We use those acronyms.
She wants to know what ADM means.
ADN is an associate degree in nursing. Nurses you can be an RN one of two ways, either get an associate degree or a bachelor's degree. Okay, then you get to be an RN. And in order to go further in your education, an ADN needs to get a BSN and then an MSN or a doctorate. A bachelor's of nursing, a bachelor's of science in nursing. As you can tell, I mostly talk to nurses, right? How many nurses are in the audience? Good. So you know some of what I'm talking about, right? All right. So how do we do this together? How do we plan this medical care delivery? How do we do this together? What we have to do is we have to stop working in silos. We have to work collaboratively. We have to work with each other, and we have to find those things that people can do based on their education and training. Am I moving too much? I'll try to stand still. Did you notice that? He's just following your So how do we do that? Well, we look at what people are educated to do, and we look at what people are actually competent to do based on their education and their licensure and training. And then we use those people in a very integrated program of healthcare delivery. That's the important part of the ACA. That's the important part of what we need to do. There's a huge part in the ACA about, that's the Affordable Care Act. There's a huge part about wellness. Nurses do really well with helping and teaching about wellness and maintaining wellness and helping you all maintain wellness. There's smoking cessation money. There is money for alternative kinds of health education, exercise, programs that get people walking together. There is money in that in the form of grants in the ACA to provide those kind of services for people. There is money for education. So if you know people who need money for education, there is actually money to repay government loans for people who decide to work in underserved areas. Up to $105,000 for each person over a 3-year period for education repayment of loans. So the ACA is a scary thing, but there's a lot of really good stuff in that bill to help support what President Obama wants to do with healthcare here in the United States. I have been known to be a Pollyanna. Everybody says Deborah's a Pollyanna. But I think what's really important, and I'm glad that we have Larry here and Dr. Cope here, so that we can make sure that you all get those different perspectives, and that you know that when the opportunity comes, that you will have a group, you'll have a team of providers that will be willing to help you to really stay healthy and to get that medical care that you need, but to be active in the preventive part of medical care too. And we hope that we can help you, that we can give you information that you need, and that you can have the information that is very necessary for you to be able to get the care that you need. Thank you.
Hi there. I've already been introduced, and some of you already know me. Let's see. And since I don't do a lot of public speaking, I decided I'd just put a PowerPoint slideshow together here. So here we go. And as Dr. Pinter said, I've been delivering babies here for over 20 years, and now this is my opportunity instead to deliver my views on the ACA. Right, if you click, then go ahead and click. Okay, right now America has the most expensive health care in the world, and yet we rank only 37 in the quality of health care in the country. Too many Americans aren't covered by health insurance, and there are too many medical errors, too much inefficiency, and too much cost. Next slide. If you take a look at my graph here, you'll see what's happened to healthcare spending as a percent of our GDP. And it's just been rising way too fast. In fact, it's actually bankrupting our country. Next slide. It's actually also bankrupting many of us. I think it is the leading cause of bankruptcy in Nevada and in our community also. If you take a look at this map here, the map on the left represents the percentage of uninsured women between the ages of 19 and 64 in our country. The dark blue represents states where 1 in 4 women in this age group are without health insurance. The light blue, 1 in 5, and the purple is 1 in 8. The map on the right side shows the changes we'll see, theoretically, when the ACA is fully implemented. Being without health insurance is actually quite dangerous to your health. Next slide. If you're unlucky enough to get really sick, not having health insurance reduces your chances of survival. So how many uninsured people do we have in the United States? Well, in 2019, without the ACA, the estimate is 57 million. Next slide. With the ACA, there will be 34 million less uninsured in the United States. And in this slide that you can see there'll be a lot of movement here. The uninsured population of the 34 million, about half will move into the Medicaid program and the other half will move into the health insurance exchange. Many people in the small group market will actually move into the health insurance exchange, and additionally people in the individual market will be moving. So there'll be a whole lot of rotation going on around that. Next slide. So we passed it, the Supreme Court upheld it, and what did we get? I think we got changed. I mean, that's really what we got. We got changed. And change is hard because we tend to overestimate the value of what we have and we underestimate the value of what we're going to gain. And so, you know, I think that's one of the biggest things that's happened here, and probably why so many people are talking about this is because change is scary. A show of hands for anyone who has received an email like this next slide. Has anyone received an email like this?
Oh, yeah.
This particular email has been the subject of debunking and fact-checking by multiple sites. Virtually every statement, and it is either exaggerated, misleading, inaccurate, or just wrong. I would just ask anyone who gets an email like this, who feels upset by it or concerned or alarmed by it, to go to a reputable site and fact-check it. You can fact-check it line by line and see what's true and what's not true. And that's probably the most important thing you can do because there's so much misinformation on the internet. And the only way you can really decide whether or not you need to be alarmed is to check it yourself. Next slide. So Snopes.com, factcheck.org are two sites that I think might be beneficial. Places for you guys to check if you do get something like this in the mail and you're concerned about it. I want to go over some of the beneficial changes for the ACA. One of the big changes is improved consumer protection. You know, in the first one I've listed here, and these are the things. In fact, Larry did a very good job talking about grandfathered insurance, but all insurance companies, when they make any change, they're going to have to come underneath these new laws.
And these new, oops, lost my, what happened to me? I'm no longer alarmed. Flipped up? Okay, thank you. Can't tell. We'll take questions still.
Maybe I can use this. Is this on? Okay, that's great, because I'm standing right here anyway. So I'm going to just go over these pre-existing conditions, these improved consumer protection. But one of the things I just want to say is that, you know, these are going to apply to all insurance companies eventually, but not immediately. No pre-existing conditions. You know, I've seen so many women over the years who come in, they had one abnormal blood pressure, they had one abnormal pap smear, and after that, when they tried to get insurance, that whole part of their body was just excluded. We'll cover you, but we won't cover anything to do with your reproductive tract. We won't cover anything to do with your heart. Everything else, fine. And that's just a terrible situation. Gender rating differences have been a big problem. Women are often charged 50% more for private health insurance, for individual health insurance. And under the ACA, that is no longer going to be allowed. And, you know, I've never thought that was fair, since part of the reason that women are more expensive in health care is because of the things that happen to them related to being in relationships with men, like pregnancy. So it just makes sense that we should even that out. A lot of health insurance that will come in have a 9-month waiting period, and you know, 9 months seems like such an interesting time, especially for me as an obstetrician. It's gestational period, and you know, they get the health insurance, they get pregnant, some of it done when the 9 months goes by, it's a pre-existing condition and the pregnancy is not covered. These things will not be happening anymore, and I'm glad to see it. I know Dr. Pinter had a son who was taking advantage of parents being able to cover their adult children. I have a son in that same category right now, so I can just say that that's a great thing. Most children and most young adults don't need coverage, but if they do need coverage, they really better get it, because otherwise they can actually really hamper the entire rest of their lives. Next slide. So preventative health services, and for Medicare patients, under the ACA, there will be no more Part B deductibles and no more co-payments for your doctors if they accept assignment for the services I have listed above here. The 4 most important things you can do to improve your health, to prolong your life, are to control your blood pressure, don't smoke, control your weight, and get vaccinated. All of these are covered under the preventative services listed above for Medicare patients. Next slide. So for adults that are too young to qualify for Medicare,
There are even more vaccines that are covered, and there are other important services that are covered also, particularly for men. Screening for abdominal aortic aneurysm is one of the covered benefits with no copay. Next slide. For women, probably the biggest changes are in this group. First dollar coverage for pregnancy and for contraception. I think everyone understands the importance of coverage for prenatal care. I want to emphasize how important the coverage for contraception is. When I was first in practice, I could put an IUD in. IUDs cost us, we pay $15 for an IUD in my office, and I might charge a patient $20 plus whatever it was to put it in. For me to buy an IUD right now, does everybody know what an IUD is? An intrauterine device. It's probably one of our best forms of long-term reversible contraception. For me to buy an IUD right now in my office, I pay $800.
Are you serious?
Actually, I think I pay more like $850. It's a little T-shaped object. It probably costs them less than $1 to make. But that's how much I get charged. So I have so many patients who have come in over the last many years wanting IUDs and finding out that it wasn't covered under their health insurance. They had to pay their deductible first. And so they rely on less effective methods of birth control, and that's not so great. In the United States, about 50% of our pregnancies are unwanted pregnancies, are unplanned pregnancy, and about half of those are unwanted. And to be perfectly honest, unplanned and unwanted pregnancies are bad for babies, they're bad for mothers, and they're bad for society. Next slide. So it makes me very happy to see that that's a coverage that we have, and I certainly, I think the whole society will benefit from that. Well, I did have to put the preventative services covered for children. They're so small, I'm sure you can't read them, but there's a lot of them, and that's a great thing. The next thing I wanted to talk about was the donut hole, because actually that is something that changed immediately with passage of the ACA. And has anyone run into the donut hole in the room?
My husband has.
So I just wanted to just explain the donut hole. The donut hole, the way it worked, is that if you are on prescription medication, each year that total amount of money that is spent on medications is evaluated, and when the total cost paid by you and Medicare pays about $2 out of every 3 for prescription expenses, and when $2,900 is reached, you fall into the donut hole. And that donut hole means that you receive no coverage. You pay 100% of your drug costs in that donut hole until your personal outlay expenses, not that of yours plus Medicare, but your personal outlay expenses, has exceeded $4,750, or till your total drug cost with Medicare helping you is up there close to $15,000. And that's really, we're talking about a lot of money here. So one of the first things that happened is that, well, people who had been in the donut hole actually got a rebate, and now each year the amount of support you get from Medicare for their drug expenses while you're in the donut hole will increase. Next slide. Until by the year of 2020, you will pay 25% for your brand name drugs and 25% generics. The government will pay 75% of both those drugs. And I think that's really going to make a difference, because this is, I think, this donut hole is probably the greatest reason why there was so much talk about, are you going to buy your medications or are you going to eat? Next slide. A lot of people have asked the question, who's going to see these 34 million less insured patients? And, you know, I think many people in Carson City have already run into the problem of not being able to find a provider, a primary care provider, who will take you as a new patient into their practice if you have Medicare or if you have Medicaid. And, you know, to be perfectly honest, that's not going to change overnight. It's going to be a long, slow process. We will need more mid-level providers. We need more primary care providers. And the ER, someone asked the question, will the ER see less of these patients? No, the ER will see the same number of these patients that they're seeing right now. The thing that's emerged is that urgent care clinics are actually cropping up. Carson Tahoe has 2 freestanding clinics, one in Dayton and one in Carson. And they've put one urgent care center in each of the Walmarts. In our valley, we have 3. Carson Medical Group has its own urgent care clinic now for after-hours services. I think that's going to be where the non-emergent patients really should be directed, particularly the ones who don't have a primary care physician for now, as we kind of work our way
to getting all of these patients the primary care that they need. Next slide. So the approach to improving the quality of healthcare, that's what they're taking a look at. And standardization to reduce error. To err is human, and what we want is to put systems in place to prevent errors in healthcare. Healthcare has become so complicated. I mean, I finished medical school over 30 years ago, and the number of drugs on the market there, I could actually probably recognize almost all of them. I mean, the number that's on the market right now is mind-boggling. It's the same with medical information. Our medical knowledge doubles almost every 90 days right now. There's no way any physician or nurse practitioner or anyone in the field is going to keep up with all the changes that are going on. So we need systems in place to prevent people from making errors. Second thing is we need transparency. We need increased transparency for patients and for families. People need to be aware of how effective therapies are, and they need to know how much they cost. And there are very few places in the country where you go in and you say, I want that, and you don't know how much it's going to cost before you get it. But that happens in healthcare all the time. We need improved communication between healthcare providers to increase the care coordination and to decrease the overlap. I mean, we have all the time, I know Susan's seen it, and I've seen it, and I'm sure Deborah has seen it, people who just had a CAT scan at this facility, now they just get a CAT scan at this facility. And that just doesn't make sense. We need to actively involve our patients in prevention and treatment. Next slide. To get this kind of coordination going on, we're going to have to actually change the way we practice healthcare. And we need to move, basically healthcare is to computers, because we need to do a tremendous amount of analysis to figure out the best way to make healthcare decisions. It's an enormous undertaking, and one of the things that is sort of helping to push this along is the CMS, because they came up with a program, next slide, called the Physician Quality Reporting Initiative. And what it does is it mandates participation from all providers of healthcare services. The goal is to get all physicians on electronic medical records and all of them submitting data to a central source so that that data can be analyzed. I mean, that's a general principle of how we're going to kind of pull everyone in the country under the same umbrella of healthcare. This is happening right here in Carson City, and I think any of you receiving healthcare probably be impacted by it by some degree. Physicians who participate in this program are reimbursed right now if they achieve certain goals that were set out by CMS. They receive a 1% increase the first year and 0.5% after that. By 2015, they'll actually have money taken away if they fail to meet the criteria that are established by CMS. Next slide. CMS is the Center for Medical Services. It's what runs Medicare and Medicaid. So meaningful use measures. This is what they've come up with. CMS has come up with meaningful use measures, and I've listed some of them on the board. How many of you noticed that you have a few more forms to fill out when you go to the doctor's office? I mean, part of this is because physicians, one of the things we have to collect is ethnicity. I mean, we have a lot of specific pieces of data that we need to collect and turn into CMS in order to meet these meaningful use criteria. And I see it as both a good and a bad push. It's definitely pushing physicians to move into medical records. I mean, physicians' practices have been sort of a cottage industry in this country. And you just can imagine taking all these physicians who have these, one doc shop, they have their, it's been very comfortable, it's been a very nice way to get health care. And that's the way the country's been run. But now we have to figure out how to pull together all those treatments, all those patients, all those diagnoses, all those results into one big data pool so that we can analyze it and come up with what the best treatment plans are. And how are you going to get physicians to do that? I mean, most of us really don't want to do anything differently than the way we've been doing it. I mean, I've had physicians tell me that the chart actually speaks to them. I mean, they pick up a paper chart that belongs to a patient they've been taking for a long time, and they can feel what's in it. There's emotion attached to it. And you lose that when you have the electronic health record. Next slide. So the positives of electronic health records are that they're actually legible. And I think that's a big deal. I don't know, we were inevitably having a critical chart get lost, and that never happens anymore, although occasionally form, but they usually come back up again. Patients now, many patients can access their medical records online. They can check their results from their laboratory studies. They can see their vaccine records. They can even see that there are errors in their medical charts that they can correct. There are fewer medication errors because we're using electronic prescribing in a much higher percentage of the time. And that means that the handwriting issue and other issues are being caught earlier, quicker. Same thing with improved use of preventative health care, because these preventative services can be flagged by electronic health records. So, next slide. The difficulties are that computers are incredibly expensive. Millions of dollars have been spent trying to achieve interconnection between computers. And we're just starting to scrape the surface. I mean, half of the physicians in this community are on one type of system. Other groups are on different types of systems. They don't speak to each other. The hospital system doesn't speak to its outpatient clinics. The machines on labor and delivery that read our fetal monitors don't speak to the hospital machines, and so all of that is really very complicated. As I said already, there've been millions of dollars spent. There'll be millions of dollars more spent trying to get this to work, and the frustration level is very high. And there actually are some bad consequences that come from computer systems that don't work well, because there is a breakdown in communication, ordering, and it can be very difficult. Protection of patient records is very good at the local office level because there's a footprint or a fingerprint, electronic fingerprint for everyone who touches a chart. But once those charts go up the food chain, once that data is pulled out and brought up the food chain, there's the possibility of somebody getting in there and getting access to health information. So security is a little bit less. It's a little less secure at the high level, but more secure at the low level. Decision screens really aren't structured to work with computers. And I don't know how many of you have been in a physician's office where they were looking at the computer the whole time, and you just felt like you weren't getting the attention that you needed to get because they had this toy in front of them. And I can just tell you that as a physician, it's very frustrating because I spent my life trying to figure out the best way to take care of the person in front of me in the room, and now I have to figure out how to put what I do into a box that comes in 1, 2, 3, subset A, B, C, with an initial subset 1, 2, 3. It takes 7 clicks to get to this box. If I don't put this in this spot, the data isn't structured, so it's of no use to anybody else. So all of a sudden, what I used to have, which was my little chart, which I loved, and recognized, these things on them or whatever. Now I have, these charts that I can read and I can access from lots of different places, which is nice. But I also have to use structured data format, and that structured data format means that I can't just write quit smoking 3 months ago or wants to quit smoking. I have to use 6 drop-down menus and put all the right X's in the right spots, or else it doesn't count as structured data, and it can't feed into the system that CMS is designed in order for us to evaluate everything. On labor and delivery, one of the things that's happening is we have the nurses taking vital signs like they always have, looking at the fetal monitor strip like they always have, taking temperatures, respiratory assessment, recovery room vital signs, all that stuff, but none of it feeds into the main computer, so all that has to be transcribed. In the past, with work clerks who could do a lot of this work for us. They could put the orders in, they could do a lot of these things, but they can't do that now. So now we have nursing staff spending 10 times as much time trying to chart now in the electronic health record than they were using before we got to the electronic health records. We have anesthesiologists in critical situations in the operating room trying to figure out how to order blood from the blood bank in order to get the blood up to the operating room. I mean, we've got a lot of problems in instituting these changes, and they're impacting us, and they're going to impact you. And there is a greater good that's going to come out of it eventually, and I'm sure the systems will become more friendly as we get the bugs out. But this is a very complicated system, and I think it's just helpful to give you guys that perspective. Next slide. Cost containment. How are we going to get there? Well, on the patient side, and I think the patient side actually is the critical side, we do need, as I said before, to make costs more transparent. We need to move towards a more consumer-driven healthcare decision-making process. One of the things that happened in Michigan with GE is that they put their employees on these medical savings accounts. So they said to the employees, we'll cover you for catastrophic health care, and then we'll give you this much dollars to spend on whatever health care you want. And in this situation, you know, with these mandated preventative health care, there's the regular health care anyone can have. And then if you get sick, you can choose what you want to do. And I think, you know, what happened to them in Michigan when GE did this is all of a sudden, the number of MRIs that were done on their employees plummeted. And that was amazing because they saved actually a whole lot of money in the healthcare outlay because of the MRIs not being done. The problem was that they were making their money selling MRI machines. So they actually needed to take another look at their business plan to figure out how they were going to survive. But what that clearly demonstrated is when consumers are looking at how much money they're spending on what they're spending it, they're going to think very, very carefully about whether or not they're, you know, is this 90% effective? Is it 99% effective? And how much is it going to cost? And where do I want to put my money? And I think having skin in the game is what we're going to see in the healthcare exchange. I think we're going to see a lot of medical savings accounts come out because they're going to want you thinking about how you want to spend that money. So, next slide. So, for those of you who can't read this, it says, "May I be excused? My brain is full." And I figure after listening to all three of us talk, you guys are probably pretty close to that place. I have one more slide to end on, and that is, embrace change. There's no going back.
That's it.
Thank you. If you want to pass any remaining questions over to the east, you can figure out the east, then you can have your question answered. We've received a few, and I'm going to start with Larry. What was the process used to opt in to the Medicare system when so many states rejected the program?
To the Medicaid expansion?
Yes, to the Medicaid expansion program.
Well, almost no states have really made final decisions, including that. I mean, we've opted in. We're planning to go into it, but that can be changed at any time based on the governor's decision. The principal reason is that the state is at almost no risk for doing the expansion. That the medical coverage part is going to be picked up for the first 2 or 3 years entirely by the federal government, depending on when it starts. And then the administrative cost will be picked up by the state, would be rolled in probably into managed care contracts is the most likely way. So it was that, I think it was that going into it seemed minimal cost to the state, and the state could back out at any time. I think that's where the Medicaid expansion. On the health insurance exchange opt-in, I think about over half the states have opted into a state-run exchange. The problem, the issue there is that it's either a state-run exchange or it's a federal-run exchange in the state, or there's a partnership. I think 2 states are actually going to try a partnership between the 2. But I think that as a growing number of states join it, it's that they make the assessment, we'd rather run it than have the federal government run it. And so that's the issue there. Mm-hmm.
Who made the decisions?
The governor.
The governor all by himself?
Yeah, the governor.
Deborah, there's a question that I think probably a couple of you can answer. What are your best predictions as to how rural Nevada will be affected by the lack of doctors and nurses with the, not only the uninsured, but with the expansion of Medicaid?
Yeah, I think all of us would have something to say about that. The first thing that you need to know is that rural Nevada right now doesn't have enough providers as it is. So that's already a problem. There is a bill at the legislature to allow advanced practice nurses to practice till their full education and competence, which would help because in fact, I know of several different, about 25% of the nurse practitioners in Nevada are having problems finding a collaborative physician. You know that nurse practitioners in Nevada have to be in collaboration with a physician in order to practice. There are, I know of at least, well, 25%, so about 150 of the nurse practitioners in this state have not been able to practice because they can't find a collaborative physician. So if this bill passes, that may help serve the rural parts of the state. There are clinics that are closed because the physician has moved out of the rural town. So that will be one way to make sure that we have practitioners who will be able to treat people. But it is a serious thing, yes.
Can a doctor live in Yerington, have a satellite office in Fallon run by a nurse practitioner?
Absolutely.
Why don't they do that in order to cover the thing?
They would like to, but those physicians aren't necessarily willing to do that.
I think I can speak to that. I am a collaborating physician for some nurse practitioners, and being a collaborating physician has certain responsibilities as well. So you have to be available to, if the nurse practitioner needs you to see the patient, you have to be available to do that. So it sounds easy on paper, and unfortunately in practice it's not as easy as it probably could be. I do think, though, that the teamwork that Deborah's emphasizing among physicians, nurse practitioners, and physicians' assistants will become increasingly important for all of us for our health care.
Susan, would you also speak to medical liability with that issue? Because I think that plays a role in the willingness of physicians to collaborate. And unfortunately, that was one issue that was not dealt with in the ACA.
Yes, and actually one of our questions has to do with medical liability. And perhaps, Larry, you know probably more than anybody else.
I think that one of the problems with racing to adopting new systems and new reforms is that we're going to have to backtrack and talk about where the accountability is. And liability is another way of talking about accountability. And in an integrated setting, that's harder and harder to do. That you don't have an individual making a decision, you have a team making a decision. And all these various ideas about what kind of integrated practices there'll be, what medical homes will be. The answer is the federal government ducked the issue of liability, figuring that they'll take that up later on when they see what goes wrong. So until that time, I think it's very hard. One of the groups that's very hard to change is our lawyers. And so I think that they will continue to try to find who can best pay in litigation. Now, one of the things about a lot of these new managed care structures and whatnot is that there will now be some kind of new institutions created, new organizations, new entities. And in many cases, the doctor and the nurse will be working for that entity. And so presumably, liability will flow with whoever operates the things. But there are, at this point, questions, there are no definitive answers, and I doubt that we're going to have them for a number of years. It's going to take cases to build up and problems to develop. That's my basic theme, is that healthcare reform is not a point in time. It's going to be a process of backfilling, changing direction, moving generally in the same direction, but at different rates. They're going to be halting steps, I think. And liability is going to be a big part of what halts those steps periodically.
Sandy, a couple of access issues I'm going to mention, and you can address what you're comfortable with. Some doctors are not taking Medicare patients. Will that increase under the ACA? My doctor now is using Fridays to fill out paperwork. This is a common problem, seeing 20% fewer patients. Will doctors need to cut their patient load? And also, what will the compensation be for physicians who take Medicare and Medicaid patients?
the last question is the easiest one to answer. Over the next couple of years, there is, I think, about a 30% additional reimbursement set up for pediatricians, internists, and family doctors. But not for obstetricians. So there is actually increased payment happening for the next couple of years at least. I think to try to encourage providers to take Medicare and Medicaid patients. One of the problems we've had is that the payments, the reimbursements have been so low that have just met overhead. So if you only see patients who